Hello, my name is Alexander Egeberg. I am an IPC counselor and associate professor of dermatology at Bispebjerg Hospital in Copenhagen, Denmark. Today I'm going to talk about real-world evidence of systemic psoriasis therapies, and I'm going to talk about what we mean when we're saying real-world data or real-world evidence and how that compares and differs from clinical trial data. So these are my disclosures. So drug survival is a term that we hear quite often, and we use it in dermatology as a proxy measure. So drug survival means the probability that a patient will remain on therapy. So if we're talking about a systemic therapy for psoriasis, it means that if you have a high drug survival, there's a high persistence of this drug, so they will continue the drug for a long time. We use this as a proxy measure of efficacy because not in all observational data, it's not everywhere that you have information about PASI or DLQI, for example. So the fact that patients remain on therapy, we tend to use that as a proxy and say, well, that must mean that the drug works since they continue. The way we look at drug survival is often either graphically via a Kaplan-Meier curve, or by getting a risk estimate, for example, a hazard ratio, where you look at what is the risk of stopping therapy. So a Kaplan-Meier curve is actually a quite complex curve, even though many people are familiar with them. There's a lot of data hidden in a curve like this, so I'll take a few minutes here just to explain how to interpret a curve. So if you look at this, there are a number of different curves, and there are a number of different data points here that we can look at. If we go all the way to the left, we can see here at time 0, we can see the number of patients who are still on therapy, meaning that they have not stopped therapy. So at the beginning of the study, of course, 100% of the patients are still in the study and they have not stopped therapy. Under each of the time points, we can actually see how many patients are still in the study at that time point. So, for example, at time 0, you have 296 patients who are treated with drug A. At week 50, you only have 74 patients who are treated with drug A. And that can, of course, be due to several reasons. So, for example, it can be because the drug was discontinued. So the patient had to stop treatment because it didn't work or it gave a side effect. But it can also be because we simply don't have enough follow-up time. So if we do a 10-year study and I look at the first year, if I started a patient 10 years ago, I will be able to look at that patient after 1 year. But in that study, if I started them 2 weeks ago, I do not have data for 1 year at that point. So I'll have to censor the patient. And that is also a reason why these numbers drop over time. Now, the more patients who are either censored or drop out of the study, the larger statistical uncertainty you will have. So if you look all the way here at time 150 weeks, you can see very few patients, and you'll of course have a very big statistical uncertainty. In the middle, in the parentheses here, you can see the number of patients that stop therapy. So these are the ones that we would usually consider a failure in a study like this. If you look at the black lines, it is not always that these are shown in curves like this, but what it shows is the patient who are censored. So of course, if we don't have more follow-up time, then they're not considered a failure, but we simply stop following them from that time point on. Whenever we have this drop on the curve, that is the example where you see a patient stopping therapy. So that is considered a treatment failure. And where I've highlighted here with the pink color, you can see a very large drop. But if you go all the way to the left on the curve, the drops are much smaller. And that's, of course, because we're talking about the proportion of patients that are still in the study. And as we have fewer patients all the way to the right, the relative reduction you will see whenever one patient drops out will be much bigger. We can also look at specific time points and estimate how many patients are still in the study or have stopped therapy. So for example, here with drug A, you can see that around week 50, then it's about 35% of patients who have not stopped treatment, so they're still in the study. And if you just look at the vertical line and go up, for example, to the green curve, you can see that at week 50, it would be about 50% of patients. So we would say that drug survival at that point was higher for drug C, meaning the green curve, compared to drug A. We can also estimate the median time to discontinuation, and that means the time when 50% of the patients have stopped therapy. And we can see that on the curve here, that it's around 40 weeks. That's the median time to discontinuation on drug A. So this is a brief explanation of a Kaplan-Meier curve. So let's look at some real data. This is a study where they compared apremilast, PDE4 inhibitor, the oral therapy, to biologic therapies. And we can see of the curve here that discontinuation is much greater with apremilast, meaning drug survival is lower for that drug. And when we look at the curve, we can see that the median time to stopping apremilast was approximately 6 months, meaning that after 6 months, half of the patients were switched to another therapy or discontinued the drug completely. So this is an indicator that this drug in that study here specifically was not as effective as, for example, the TNF inhibitors, ustekinumab, or IL-17 inhibitors. Well, what happens here when we see all the way to the curve? This is the last data point we have. This is the last follow-up. And we can actually see here that at 1 year, it's only 1 in 4 patients that are still on treatment, or actually 23% of patients who remain on therapy. The rest of them had stopped therapy. So this tells you something in clinic. This tells you how many patients in a population similar to this, how many patients can I expect will still be on therapy after 1 year? And it's about 23%. Well, what about new biologics compared to the old biologics, for example? Well, this is a study we did in Denmark and recently published, where we looked at all patients in the country who were treated with biologics for psoriasis. And you can see each curve here, and each color represents a different drug. Now, if we just look at the median time to discontinuation here, you can see that it's roughly 18 or 19 months for etanercept. And if we look at adalimumab or secukinumab here, it is around these 36 months. So what does this mean? Does this mean that etanercept automatically performs worse than adalimumab in this study? Well, we need to remember here that this is not a randomized trial. Some patients have tried 1 biologic before, some have tried 5 biologics before. Some are men, some are women, some have comorbidity. And all of this we, of course, need to consider as well. So another way that you can look in curves like this is that we can look at drug survival in bio-naive patients or non-naive patients. So if we look at patients who have previously failed at least 1 therapy, we can see the curves are much steeper, meaning that the probability of discontinuing therapy is higher. And here we can see again, the median time to discontinuation with the etanercept is, at this point here, it is 20 months. Now, when we look at this, we can see differences, and we can see that newer biologics tend to perform slightly better than the older biologics. But again, we know here that this is not a randomized trial. These patients have different patient characteristics. So again, some may be smokers, some may be non-smokers, some may have psoriatic arthritis at the same time, or diabetes, or be overweight. All of these factors that in daily clinical practice can influence which drug you choose, first of all, and can influence the risk of getting side effects and stopping therapy for a number of reasons. So one way that we can address this in studies is that we can try to do these hazard ratios I talked about before. And when we look at these hazard ratios, we can adjust for all these differences between the drugs. So in this graph here, you can see that we've actually ranked the drugs. And the dark green color means that the confidence interval does not cross 1, meaning that you do have a p-value less than 0.05. And the light green shows you that there's a tendency, but you don't have statistical power to show it. What we can see here is that the newer drugs all are ranked higher than the TNF inhibitors. So the IL-17 inhibitors, IL-23 inhibitors, and IL-12/23 inhibitors are all ranked higher than the TNF inhibitors. So for example, here we can see that if we look at ixekizumab just as one example, compared to infliximab, we can see that there's a 70% higher risk of stopping therapy with infliximab versus ixekizumab. So ixekizumab performs better. We can see the same here with ustekinumab, for example. There's a more than twofold higher risk of stopping infliximab than ustekinumab. So ustekinumab performs better. And we can look at this with all the drugs, and we can get some sort of idea of how these drugs perform in real life. But we also know that there are these differences in real life, because in real life, some patients would not be eligible for a clinical trial, and some patients would be eligible for a clinical trial. And we can also see from data that these patients actually perform very different in real life. So this was a study from the UK where they looked at the ones they had in their biologics registry, and they looked at patients and stratified them based on who would not be eligible for a clinical trial if you look at the standard exclusion criteria. And then they looked at who would be eligible. And what they found was that patients who could have enrolled in a clinical trial actually had a higher PASI reduction over time, meaning they had a better response to therapy than patients who would not be eligible for a trial. So even if the same drug was given to these patients and the same drug appeared to work in both patients, it appeared to work better in the ones who could be enrolled in a clinical trial, typically because they had less comorbidity, they may be younger, they have less risk factors, and so on. So what does this all mean, and what should you take away from this talk here? Well, first of all, it means that when we're looking in real world evidence, we are looking at real populations of real people treating in a real clinical practice as you would in that local center or in that country. So it means that you can look at patients who would have been eligible to enter a clinical trial, but you can also look at all the other patients that would not have fit into that trial because of contraindication or another reason. So this can help you when you look at your own patients in daily practice. This may be more transferable if the patient population in the study you're looking at resembles your own patients. We can also see from this data here that luckily some of the newer therapies that are being approved actually appear to work better than the older therapies such as TNF inhibitors. But this is very important, the last point here. It's very important to remember that just because we call it real world evidence doesn't mean that it is ranked higher in the evidence hierarchy than randomized controlled trials. Randomized controlled trials show efficacy in one setting, and real world evidence shows it in a different. And these two should be combined, and together, based on trial data and observational data, you can make a decision for your patients. But observational studies alone or randomized trials alone are not enough. We need to look at them together. And with that, I'd like to thank you for your attention here in this talk.